Hi, this is Scott Aldrich with Modus GI, and I'm here this afternoon with Dr. Raman Muthusamy, who's the Medical Director of Endoscopy at UCLA Health. Dr. Muthusamy, thank you so much for taking the time to speak with us today.
Great. Good to be with you today, Scott.
So I'd like to kick things off by just asking you a question around your critical or more urgent cases where patients are admitted and they really aren't able to fully prep for their colonoscopy. So how do you and your colleagues handle these types of patients?
Yeah, so there's different sorts of scenarios. There's the scenario where the patient really can't drink because of a medical condition, in which case we often have to place a nasogastric tube and sort of instill it that way. And the other challenge sometimes can be is these patients are bedbound or critically ill and have impaired motility. They may also be on narcotics for pain or other issues. And so all these factors we know affect GI tract motility, colonic motility, and may sort of prolong the nature of the prep. So sort of doing a standard colonoscopy prep that would work great on a healthy 50-year-old for a screening exam as an outpatient is not going to get it done for these folks. And so there's some strategies that we use. We may put them on clear liquids for a couple of days in advance. We may double the prep, but again, that just means more volume and more difficulty over a longer period of time, longer period of fasting for these patients, without nutrients, although they may be getting an IV. So, but it's a challenge, and it's hard for the caregivers to sort of time all these prep dosing and to remember not to give them solid foods and so forth. And at the end, even despite all these extra measures and extra time, we may still run into issues of sort of a less than adequate prep. So it can be a challenge both for inpatients, both from an ingestion standpoint as well as a motility standpoint.
Yeah, and that seems to be the common theme we hear from most of our partnering physicians. So in these patients, how does this impact your visualization and ability to treat and diagnose, overall, the lack of prep?
We know that the colon it's a very large part of the GI tract, and the lumen diameter is larger than, for example, in the small bowel. So there's a greater ability to pool. And so it's very easy to have areas where you can have debris that can really cover up a good chunk of the mucosa. And because there is such a large surface area, both based on circumference as well as length of, the colon compared to esophagus or stomach, a lot of the lesions that we, are subtle. So for example, if you're doing the indication, for example, is to find a polyp or something like that, particularly with the large folds in the right colon where you have to look behind the folds, or these flat sessile serrated lesions, which are very subtle. You can see that even a small amount of residue or debris could easily cover up some of these sort of lesions. And we consider a big polyp 2 centimeters, but 2 centimeters is still an inch. And, so you're talking, you'd only need something the size of your thumbnail to have a fluid or debris over and you could miss it. And we know an adequate prep is critical performing a thorough and effective exam.
Sure, that's certainly not an easy one, and it certainly is a challenge for your caregivers, and honestly, a challenge for the patients as well. So I appreciate you kind of walking us through that. So how does this inadequate prep, inability to prep, really affect your ability to diagnose and to treat?
Sure. If there's a poor prep, the concern is that there may be some combustible gases in the colon that could be triggered by a spark or, for example, from electrocautery. And so generally, for example, if we have a large rectal lesion, that's why we don't typically do a flexag. We tend to do a full colon prep simply because we're worried about upstream gases. Now, I think that risk is quite uncommon, fortunately. So you don't hear about a lot of explosions in the colon, thankfully. But it is a theoretical risk, and frankly, even having that happen once would be too much. And so that's part of the reason that we are very particular about sort of an adequate prep for, especially when large polypectomy is planned.
Well, I'm certainly glad that you can't speak to any scenarios of an explosion of the colon. That's for sure. But I'd like to turn our attention now to the peer review system. And I'd like to see if you could point to, how peer review plays in this dynamic and with these patients, and how peer review might be able to better the algorithm here. So can you speak to that, and then to maybe any successes you or your colleagues have had, or any specific successes that you or your colleagues have had with the system?
Yeah, I think I'll break that question up into two parts, both on the inpatient side and on the outpatient side. So on the inpatient side, certainly we know that for the reasons we just discussed, hospitalized patients with their challenges in prepping, both from motility as well as ingestion, it's not uncommon for people to come down, they go in and then they find out the prep's not ready, send them back up one more day. And sometimes this can happen even more than once. You may end up having a patient, twice, thrice come down before they're adequately prepped. And so that's a needless delay. It's a cost for the healthcare system. It sort of takes up valuable GI lab space. A lot of these people are sick, and just getting them in and out of the unit is a bit of a production. And most importantly, it's hard for the patient, who's had to kind of go through this multiple times, potentially get sedated several times, only to not have to get the full performance of the exam. So I think from those standpoints, the ability to sort of take something that's 50-60% of the way and get it done in one session is a great advantage, both for unit efficiency, hospital stay, and again, for patient satisfaction and comfort and safety. So all of those things, I think, are important roles. Now, for the outpatient setting, you might think, well, it's a little bit more different, but there are different challenges. So, in my practice and in our interventional group's practice, we see a lot of people for colonoscopy who are referred for large polyps for resection. And many of these people drive several hours to come see us at UCLA, and certainly in Los Angeles, several hours may not be that great a distance, but it's still several hours. But a lot of these folks are not keen to drive into the big city from where they live, and they'd like to minimize the number of times they have to come. And certainly they don't want to come find out the prep was not adequate. And as you just mentioned, we're doing polypectomy, so we need a good prep for both safety and visualization. And sometimes we've actually even had to tell people, because they drive several hours, you may need to stay in a hotel because, to get the adequate prep. And of course, that's an additional cost on top of whatever copays they may have for the procedure. So recently, one of my colleagues, Dr. Sederat, had a case where someone who he was doing a surveillance of a prior EMR who had come, and actually we have known that there were issues with prep quality and challenge from prior surveillance exams. And once again, they came back and the prep quality was relatively suboptimal. And, he had two options. He could reschedule this patient to come again, and for all the challenges associated with that, or sort of try to do the exam knowing that, I didn't see everything and I'm probably going to have to bring them back sooner, which again is an additional challenge and cost. But he was able to use PureView to actually really get a very good Boston Bowel Prep score to up to 8. And in fact, in one of the areas where there was debris and incomplete visualization, there was a flat polyp and large enough to require sort of snare resection. So again, that would have been missed. And, particularly some of these follow-ups, I think the next appropriate interval would have been 3 years. And if you would have missed something there, that would have been 3 additional years of potential growth. So it is important to get a good exam in, and that converted a procedure that would have either had a missed lesion or required a repeat exam in a short time, and turned it into a one-step success. And I think the patient and both Dr. Sederat were appreciative of that.
Yeah, no, that's a great overview and obviously a great case study as well. Well, look, this has been most helpful, and we really appreciate you taking the time. That's all we have for today, but we look forward to being in touch again soon.